This is a case of a patient with a mature white cataract and a pannus along with superficial vascularization extending from 3 to 9 o'clock position, sparing the visual axis. By now, the side port entry is made, and under the air bubble, a trypan blue dye is injected. This stains the anterior capsule. Viscoelastic is then injected to form the anterior chamber and to remove the air bubble. The next challenge that we encounter is the step of the capsular rhexis. Since the majority part of the rhexis will have to be performed blindly, as more than one-third of the cornea is opaque. The rhexis is initiated in a site where there is a good visibility. A triangular flap is created and make sure that there is no extension in the early stages. Throughout the entire process, it's always essential to make sure that the flap is always triangular and folded, which itself prevents the runaway of the rhexis. Now, approaching the area which is underneath the pannus, we use an endoilluminator in order to get a better visualization of the capsular rhexis. This helps in finally completing the rhexis in a circular manner. The final pole of the rhexis should be towards the center. Now, through the clear corneal entry, hydrodissection is attempted underneath the anterior capsular margin. In these hard cataracts, it is often difficult to appreciate the passage of the fluid underneath the nucleus. Always make sure that the nucleus is tapped in the center to decompress the bag. Phacoemulsification is now initiated, and in this particular case, the stop and chop technique was employed. The trenches are created at one end of the nucleus and all the while staying in the center. As the visibility is hampered in the opposite pole, trenches are limited only to the exposed site. Once the trenches are of sufficient depth, the cracking is then initiated. The nucleus is then rotated 180 degrees and the crack is completed on the opposite side as well. We now have two complete halves of the nucleus. Now, in phaco 2 mode, with minimal power and with an adequate amount of vacuum, the nucleus is held, it is slightly lifted up, and the chop is then initiated. In these cases, especially because the periphery has the pannus and the visibility is obscured in that particular region, it is always better to bring the nucleus to the safe zone in the center of the pupillary area. Throughout the entire process, there is very less movement of the phaco probe. Now, rotating the other half of the nucleus and once again burying the phaco probe into the nucleus substance. The phaco chop is then done. The chopper can often be used in aiding in the breaking down of the nuclear fragments. This helps in conserving the power from the phaco probe. Getting the right balance between the phaco power, the vacuum, and the fluidics helps in getting the nuclear fragments emulsified in a very safe and controlled manner, all the while protecting and preserving the corneal endothelium, especially in these cases where there is a suspected compromise of the inferior aspect of the cornea. The thick epinucleus plate is also manipulated using the second instrument, and this is aspirated as well. Now, in retroillumination, using the bimanual irrigation aspiration cannula, the cortical matter is then aspirated. Now, switching hands, The cortex from underneath the opacified area of the cornea is removed as well. Under irrigation, the foldable intraocular lens is injected into the capsular bag. And with the help of the dialer, the trailing haptic is then dialed into the capsular bag as well. After a thorough wash of the anterior chamber, the side ports and the wounds are then hydrated and the case is finally closed.